Good morning. What a build-up. What to follow. That's probably the politest thing Lee's ever said about me in the 2 years he managed me. I will apologise in advance, as I always do. This is probably not the same sort of presentation that you would get from one of my compatriots in the NHS. I'm not NHS born and bred. I come from the fluffy woofy world of venture capital, retail and manufacturing. So it might be a little blunter than you are used to. Okay. I have a PFI. It's a very expensive one. And I also have a very big deficit, but don't tell the wife. And here we are. We are the newest hospital in the East Midlands. It was actually built in 2007-8. It cost nearly £350 million. And my average budget is about 475. We have specialist services as well as district general hospital services, including spinal, vascular, bariatrics, and we're a cancer centre. When it was built, it had 1,200 beds on our second site. And at the time, the 35 operating theatres that were built inside it were thought to be in excess by about 50%. I'm full. I actually have identified that unless I improve my efficiency within theatres, I need another 5 theatres. And I need that to cope with this demand, which is why I need to be more efficient, because I can't afford the £15 million it would take to actually build those theatres. I have over 8,000 employees, and as I said, it's a very nice new hospital, so I have a very low infection rate. Apart from boosting my ego, the reason why I showed you that was actually the last comment. It's what we do. And that's where we've taken GS1 into the hospital. It's now just what we do. We started off with the original objective being I needed a stock control system. I'd worked previously as a consultant in 2 or 3 other trusts, and I've still really got to see an NHS trust with a proper stock control system, or one that I would call a stock control system from a retail manufacturing point of view. So we were looking for a system that would actually provide us with a front end for a lot of work that we've been doing on our electronic catalogue system. So we already had electronic catalogues with contract-based item data, validated data in terms of product specification. And what we didn't want to do was actually throw away all that work that had been done in the previous 3 to 4 years, and we were looking for a system that actually would be our data capture system that would actually provide the front end. And we actually found it in Australia. It was a small company called hTrak who had actually been doing this in cardio cath labs and in Australian private health for quite some time. And that was really our point of care scanning. Because one of the things is, from a retail point of view, I could never understand why we're quite happy, and this is brand agnostic, by the way, why we will not want the same information that Sainsbury's have about you and all the work that you do when you're in their store and what you buy, and actually what we need to know about our patient. So one of my targets is that actually each of my patients in Derby at some point in the future will actually have their own Derby Advantage card, and when they walk into outpatients, they will swipe, and that will be the opening of their record. So that's actually our ultimate aim. So it's a very small unit. It's no bigger than a mobile phone. It's not very sexy, so people don't want to steal it. It works very well, but the best thing about it is the quality of its scanner. And if you've ever had your windscreen replaced at the side of the road, it's the same scanner that the rather brutal gentleman from Auto Windscreens will use to actually record replacing your windscreen. And if he can use it at the side of the M1, we can certainly use it in an operating theatre or actually in a clinical space. So we scan high-value items. At the moment, I have a frustration that we're not moving quicker with GS1 in terms of the drive that I was used to in retail. Yes, it did take time, but we do need to move faster, because the thing to think about is it could be your mother that we're trying to trace in terms of the implant or the consumable we're trying to recover. So please, if we could get on it in the supply chain and also with all the effort that we're trying to make with legislation, it would be a great help. We put low-value items in packs, we scan surgical trays, and we scan scopes. So I have full availability and traceability. We've even utilised our own GS1 barcode licence, which every NHS trust has. It's already paid for, so actually it's something free. You should use it. So we've actually developed our own GS1 barcodes for standard kits, as you can see, for gowns, and drapes and gloves. We also, working with our anaesthetists, have a standard pack for a general anaesthetic kit. So we don't have to actually swipe everything. It's already in the kit, it's all prepared, it's one swipe, and it's actually in use. And then we've worked with individual surgeons to actually provide standard kits for standard operations. So this is Mr. Leader's lap chole kit. And you can see we actually allocate all those stock items against the products when we're just with one scan. Here it is, all pre-packed the night before. Nobody has to go looking for anything. It's all there, it's ready to go as soon as the patient is wheeled into the anaesthetic room. Again, you can see there's a tracheostomy kit on the left and an oral basic kit on the right. So again, we're trying to standardise and speed up the process but still keep the stock control recording going and the traceability. Again, we have barcodes, which again we've developed using our own GS1 licence, where these items are actually pinned and laminated onto the theatre wall. So my OPDs can actually scan whatever equipment they're actually using. They don't have to look for the barcode on the item. They can actually scan it and ensure that they've recorded it. So I already have, from point of scanning all the way through my PO and accounts payable system, an ordering system that is managed and controlled by my electronic catalogue, and then seamlessly that PO will actually be transmitted electronically to my supplier base. I'm currently working with about 9 or 10 suppliers where actually my orders go directly into their ledger. There is no manual input from the point that those products are actually scanned at my patient in theatre. No manual intervention whatsoever. The next manual intervention is when the product is delivered back into stock and my stock control clerk actually wands it into his inventory. So we commenced in November 2013. We sat and planned for about 4 or 5 months and rolled out in a very appropriate day, the 1st of April 2014. And we went into general surgery, purely and simply because it gave us the most options in terms of specialty. And if anybody's ever tried having a PLIX discussion with a surgeon where you're apportioning consumables, you're wasting your time. He's not interested. We left it there deliberately for about 9 months to learn the lessons and develop the system to where it is now. We then rolled out into day case theatres, and as you can see, our rollout plan has speeded up as we've gone on because of the lessons that we've actually learned. Actually now, we had targeted first quarter 2016 for trauma and orthopaedics. We're still not there, but I believe it'll be going in within the next month or so. And then we believe we will be out in wards and outpatients no later than November. And this is where we are. We're operational in 9 theatres, 7 day case. As I said, I've only got 8 theatres to finish. And again, everything is tracked in there. So my patient is scanned and checked. My staff are scanned and checked. If you're not in theatre, you're not counted. That's been an interesting lesson for some of our consultants. We track absolutely everything that actually touches the patient, and at the same time, the system will actually monitor whether the product is out of date. If it's out of date, it will flag before it's actually used, and the surgeon has the ability to either delay and call for another item or actually make a decision whether he thinks it's fit to be used on the patient. And then I'm able to attribute cost to scopes and instruments and track planned maintenance. The system itself actually underpins my PLIC system because it's actually the costs of that particular patient. So there's no discussion. And there's no discussion because the surgeon's actually standing alongside the lady who's actually scanning it in. So he can't argue that she's made a mistake because he's there. So my clinical team save time. They don't have to order any product now. I've halved my stock takes, and actually I'm actually got perpetual inventory because my stock guy is actually told what should be on the shelf at the time he puts the replacement order on. So you can say that actually I have perpetual inventory ongoing. And it's helping me consolidate orders and drive down delivery charges. And Pat asked for identification. We believe conservatively we're saving at least £25,000 a month in just those three areas: general surgery, imaging and cath labs. We expect that to more than triple when we roll out into orthopaedic surgery and when we've got some more detail on the other areas. And that's actually after the cost of the system. So that's my bottom line impact. Right? I now have over 400 electronic catalogues, and we have our data ready to benchmark with like-minded organisations so we can start putting procurement together and start talking on a different basis to our supply chain. And we've also made major changes in our income. So as a result of implementing the system, we were originally at point 2 in terms of discussion with our clinicians and the validity of the information that we were able to talk to them about in terms of their clinical variation. We now believe that we're at 5. In fact, we know we're at 5 because those discussions are now happening. And this was, or is, the Crude data that first came out of the system. And the reason why I put this up, it just shows you we record the individual procedures or against that patient. You will see as well, we actually have down at the bottom the theatre staff and who is in the theatre at the time and the role that they are taking. And then that carries on. And as you can then see, there's a full list of all the consumables. And this is a 6-page document for one procedure. Just think about the time it would take to manually record that same information. I get it done in seconds by scanning the barcodes that we issue. And then I know fully what the situation is for that particular patient against the procedures that have been undertaken. And Keith will go on to actually explain how we're using that information at the moment. So we scan consumables, we have automatic stock, we can identify stock. This is actually a stock replenishment system that we now have with Synthes, where they're responsible for maintaining the stock within this unit. They actually also supplied it to me free. I don't pay for that. I don't pay for any of the stock until I use it. And that, to be honest, is the message with respect to my supplier base. I'm fed up with being a warehouse. I want to pay you when I actually use your product, not when you decide to deliver it. So there's one to think for. And actually we talked about UDI and product recall. I apologise for the plagiarism, but I'm able to actually, at the push of a button now, trace any implant and any consumable to the patient should I get a product recall. And it's not a thought, that's there. That's actually a screenshot off the system when I'm actually trying to trace a particular product and the patient on which it's being used. So GS1 gives you the common language. What you then need to do is ensure you have a system that can capture that data and actually give you the power of the management information that GS1 will give you. Okay? That's where we need to go. And our next big project will be, we intend to hit all our rooms with global location numbers. So I have room identification and associated equipment, and actually what those actual rooms are used for, which will help me with my estates and facilities move into Carter. Okay, so that's the boring bit. Hopefully you'll get a bit more stirring from Keith. Okay.